Hola, soy Rosario Custidiano, soy hematóloga acá en el Instituto Alexander Fleming. Nos visita el profesor Arnon Kater, que es hematólogo y profesor senior investigador en el Centro Médico Académico en la Universidad de Ámsterdam y es investigador principal del estudio GLOW, un estudio muy importante en Leucemia Linfocítica Crónica. Lleva más de 20 años en el campo de la investigación en esta patología, tanto en Europa como en Estados Unidos. El objetivo de su visita a IAF hoy es compartir con nosotros su profunda experiencia y poder debatir situaciones clínicas que representan un desafío en nuestra práctica. Vamos a conocer un poco más en profundidad cómo piensa, cómo ve él lo que está sucediendo en el campo de la investigación y del tratamiento de la leucemia linfocítica crónica y del cáncer en general. Thanks, Arnon, for being here in Argentina. What inspired you to pursue a career in hematologist, immunology of cancer, and clinical hematology? And how have these fields evolved over the course of your research career?
Yeah, well, that's an interesting question. So to go very short, what I always liked very much in medical school is a combination of laboratory and of medicine. So not only following guidelines, but actually helping to create data that actually can shape the guidelines and the new treatments. And then I found out that within internal medicine, that hematology is so much changing. And actually, when I started medical school, it was 99.9% was chemotherapy. And I had the feeling that indeed, if there's going to be a big change in some parts of internal medicine, it's probably the hematology oncology fields. And within that, if you like laboratory medicine as well, then hematology is a very interesting disease to study, or a field of diseases, since it's so close to a lot of new discoveries that were made with all the new techniques that we have. And indeed, it turned out to have a major impact. And I remember that my first time I went to the ASH, the American Society of Hematology conference, then CLL was not interesting at all. It was like in the smallest room in the back of the conference center, and now a few years later it became more and more changes happened. So it was not only chemotherapy but much more targeted agents. And I think we can actually say that because of a lot of developments in CLL, which all the studies that everybody have been doing, that we not only changed CLL, but we because of the CLL studies we also changed other diseases like venetoclax for AML, for instance, or bispecific antibodies, how T-cell dysfunction works. So CLL is not only a disease that should be treated very properly, but it's also a very interesting model to study other diseases.
Well, and in your experience, what are some of the most promising avenues of research in understanding the interaction between the immune system and cancer cells?
Yeah, so the interesting thing of CLL is the very unique thing of this disease is that it's almost like an amplification of normal immune interactions, but then in a crazy way almost. So the CLL cell is a B cell, but it's a malignant B cell. But instead of other malignancies, it really it's almost addicted to signaling from the outside world, and therefore it creates its own microenvironment.
Supporters.
Exactly, yeah, it really needs supporters. So if you like immunology and hematology, I think the fact that those B cells need T cells, needs macrophages, needs dendritic cells, by studying CLL, you actually learn a lot on the normal immune system, because it's kind of almost like if you look to a magnifier because of the CLL, which everything is so much more exposed to in this lymph node environment.
Mm-hmm. Could you elaborate on the challenges and opportunities in translating experimental findings in immunology and hematology into clinical practice, especially in the context of cancer treatment?
Yeah, so many discoveries that were done in the laboratory actually showed that targeted agents can actually work in this disease by targeting specific pathways that inhibit this crosstalk in the microenvironment. Of course, you can't do it alone. You really need a pharmaceutical industry together to go to this direction. The challenge is that it's not always exactly the same, the wishes of the pharmaceutical industry and the doctors. And there's always this issue of making profits. And you have to work around that. You have to respect that somehow, but you need to fight it a bit to get the best of your patients. And I think the best example is that it took actually a long time to convince companies that continuous treatment, for instance, with an BTK inhibitor, might be most interesting for companies, but maybe for patients it's better to give a finite treatment.
Yeah.
And it takes time, and it takes persuasion. It takes also patients themselves to be more vocal. But in the end, you find each other. But that is the challenging part.
And what are some of the key considerations when designing clinical trials for novel immunotherapies, and how do you ensure patient safety while maximizing therapeutic efficacy?
Yeah.
This is very important.
So the counterintuitive problem that you have with immunotherapy for cancer is like we are both trained in a way that you can only expose your patient to novel agents when there are no good available treatments anymore. So a typical phase 1 patient, there is either this treatment or there is nothing. And the problem is that we have been trying, not we as person, but like we as community have been trying to go for immunotherapy in cancer for a long time. But we know that specifically with chemotherapies, we also kill this immune system. So to try an immune therapy in a setting where there are no or hardly any more viable immune cells left anymore, that is a big challenge. So I think one of the reasons that it took a very long time in oncology and hematology to get these treatments is that you have to give them completely at the end of the road. So I think, again, CLL can be a very good example, because now that we have more and more patients that have never got this T-cell depleting chemotherapy, we now actually have a chance to take patients into a phase 1 trial while they do have at least proper numbers of immune cells left to see if there is an activity or not. And actually we are doing this with bispecific antibodies. Others are doing this also with CAR T cells. And so maybe because of this revolution from chemo to targeted agents, we actually are going also to be more successful in developing immune therapy.
I think it's a great example. As a clinician and a researcher, how do you approach balancing the need for rigorous scientific evidence with the urgency of providing innovative treatment to patients with advanced cancer? I think in relation one.
Yeah, that is that indeed. So it's always a challenge that researchers are mostly very curious, and you want to try maybe very quickly to find evidence that something is working. But on the other hand, you also have to respect that a patient has good options also without your research, and you should really balance the good you will do to a specific patient versus the possible side effects that you have. So it is, I mean, the reason that I think the same is true for this hospital, that people come to me also because they know that if other doctors say, well, we don't have much options anymore, that's because of the trials that we do, we might have novel options. It feels like a double obligation. So if I get a patient and I have a trial, I try to enroll him or her. On the other hand, you can also harm patients by putting them too early into a trial. So you really have to, you have almost like two faces. You have the patient doctor that very strongly protects the patient from unneeded harm, but you also have the curious researcher that wants to put somebody in trial, and that is a balance that you have to be aware all the time, and you have to know which role you play, and that if you have a patient in front of you, that the first thing you have to be taken care of is the health of that patient, and that should be more important than your curiosity. And I think it's, I hope I do it, but that is a challenge that probably you face also in this hospital, where you have a lot of trials, that you always have to find this balance where the patient that is in front of you always is more important than the possible patients in the future that you might save by doing this trial. But that's a balance, yeah.
Yes, and also I think that trying to imagine a scope of a future beyond what you are doing at that moment. So I think that also is like a...
Yeah, and also what's interesting is when I started hematology, you also had these phase 1 trials with extremely toxic chemotherapy. 15, 20 years ago, the chances that you really were adding life to a patient with a phase 1 was very small. But now with all the new agents that you have, it's actually also for the patient that's in front of you, not only for a future patient, that the phase 1 might actually help. So that makes it for people like us much nicer also to put patients in a trial, because the toxicity we understand much better and the efficacy is probably much higher nowadays than it was 20 years ago. So it is also changing that patient, you can really help not only future patient, but also the patient that goes into a trial.
So I think it's an amazing present, and I think...
Right. Yeah, it's really nice to be a hematologist now. Agree.
At this moment, so we can agree with that.
Yeah, perfect.
And I think it's a great news also for patients and for CLL patients. Right. So I thank you so much for being here, for doing all this effort, keeping the trials and the patients and doing hard effort. Right. So thank you so much.
All right.